All right, I think we're good to go. We have a case for everyone this morning that's going to be presented by Christine and Rebecca. So, Rebecca, go ahead and take it away. Tell us about the case you guys admitted.
Okay, so this is a patient. He's 57 years old, male, has a past medical history of hypothyroidism. He initially presented to an outside hospital with hemoptysis and was being transferred to us for bronchoscopy for further evaluation. Some of the relevant findings at the outside hospital included a CT chest, which showed a partially calcified right hilar mass lesion with right hilar adenopathy that had some evidence of necrosis. He also had multiple peripherally calcified parenchymal nodules, read as most consistent with old TB. There was also airspace disease in the right lower lobe predominantly, but also in the left upper lobe and right upper lobe, and then calcifications in the liver, spleen, right kidney, and porta hepatis lymph nodes. Going into his past medical history was just significant for hypothyroidism. Past surgical history really wasn't significant. Just removal of cyst under the left axilla about 10 months ago. There was a family history of cancer, ovarian cancer in the sister, and colorectal cancer in another sister. And in terms of social history, he didn't have any recent travel, no history of latent TB, no positive PPD, no incarceration or homelessness. Has smoked for a pack a day for over 20 years.
All right, any other questions about this case?
Where's he from?
He's born in Wilmington and he's from the area.
All right, we got one in the chat. Any fevers or night sweats?
No fevers or night sweats.
How long ago did he have his latent TB diagnosis, and was he treated?
Oh, no history. No history of
Oh,
latent TB. No positive PPD.
Okay.
Yeah.
Oh, sorry.
Um,
That's my bad.
he had hemoptysis the morning that he presented to the outside hospital, which was like a week before he presented to us.
Was he still having it?
Yeah, so he was still coughing up about half a cup to a cup a day. And when he had coughed in the helicopter ride on the way over, and he had like the pink bin, and the bottom of it was covered with blood.
Oh, wow. Okay. All right. Any other question? Oh, you can see the chat, right, Rebecca? Or do you want me to read them for you?
Saw it. No history of chemical exposures. He works as a realtor. Pretty stable job.
Is he on any medications at home?
Synthroid for hypothyroidism.
Who does he live with?
He lives alone with his pet dog.
Any lymphadenopathy that he's noticed, and any skin changes, any rashes?
No lymphadenopathy that he's noticed. This came out of the blue, and no rashes or skin changes.
Any drug use or IV drug use?
He drinks 2 to 3 drinks a day, but no drug use or IV drug use.
How about travel?
No recent travel.
Does he do a lot of work with the homeless population?
Not that he told not that he told us.
Right. Any other?
Any hematuria?
No hematuria, no bleeding anywhere else.
I think recent history of sputum production.
No. So no cough, no sputum production.
All right. Ever been tested for HIV?
Yep, he's tested negative in the past.
I think, if you still want some more history, feel free to ask them, but I think we'll move on to, before we do breakout rooms, to, physical exam, laborations, all that stuff. Anything specific on physical exam that popped out, Rebecca? Oh, vitals too. How was his vitals? Sorry.
His vitals,
If they're all normal, if everything's normal, it's totally cool to just say normal too.
they're all normal, and he's
Okay.
satting well on room air. He never desatted.
No DSAT.
Um,
All right.
So Christine saw this patient, so I'm going to have her tell us about the physical exam.
Sounds good.
Yeah, there wasn't really anything very remarkable on exam. He had that one episode of hemoptysis in the copter when he was like en route to our hospital, but I didn't see him like physically have any sort of episode while he was while we were seeing him.
Okay.
And there wasn't anything really notable on physical exam, like no rashes, no lymphadenopathy that I appreciated, no lower extremity edema, heart and lungs were within normal limits.
Okay, sounds good. All right. And then maybe we'll give some of the more basic labs before we break out. Just anything abnormal on the CBC.
CBC, the white count was 10.1, hemoglobin's 10.3, platelets 200, pretty unremarkable.
Okay. Anything weird on the Chem 7, or is it just normal?
Normal.
Normal
LFTs
for a
were normal. Coags weren't that remarkable. INR is 1.15.
And his hemoglobin at the outside hospital on day of admission was 16.
Okay.
No.
So just a lot. All right. So now we're gonna do the case and mini cases, just so we get some more learning in there. Where's breakout room? All right. Oh, I got them. So let me make your breakout rooms real quick. 4 rooms. All right. Can you guys see the breakout rooms or no? I always like say no. Okay. So breakout room 1 is Amanda Kahn, Amanda Matheson, Ashley Barnes, Madison, Stephen Montebianco, and Travis. Tell me what you think about this case. Further workup and management here. But you're also going to have mini question 1. And I'm going to put these questions in the chat for you guys. So you're also going to have this question too. This question here for this patient, a 40-year-old, past medical history, infertility, chronic sinusitis, recurrent colds with nasty sputum production over the past few years, comes to the hospital. Notes that he's filled a few cups up with foamy blood in the past few hours and won't stop. CT scan is shown. What is your differential diagnosis and how do you want to treat this patient right now? So you guys will do kind of the main one and then also this mini question. Breakout room number 2 is Allison, Candace, Eric, Josh, Rashi, and Ryan. You're going to have mini question number 2, a little different. This is a 25-year-old female, past medical history of asthma, presents to hospital with acute worsening of her shortness of breath, scant foamy red sputum, as well as dark urine. CT to the right, UA with microscopy as dysmorphic RBCs, 3+ protein. Notes a mild drop in hemoglobin. What's your differential for this case and how would you want to treat this? Just generally, how do you treat this kind of illness here. You don't have to get too specific unless you want to. So breakout room number 3 is going to be Hillary, Jesse, Susie, Julian, Mario, and Samip. This patient, 35-year-old female, past medical history of metastatic colon cancer, presents to the hospital with acute onset pleural chest pain, scant hemoptysis. A little tacky, but otherwise no, she feels well. The ED gets a dry CT, which is shown with that abnormality in red. What is your most likely diagnosis, and how do you want to treat this? And you can be specific with treatment, especially with the journal. And then Mr. Gillo Asper is a HIV patient, history of cavitary TB, but was treated for the TB well, but now he's coming in with massive hemoptysis with a CT scan shown to the right. Question for you in breakout room 4, which is Danielle, Ellie, Max, Sam, and Tara, is what is this diagnosis? And then the patient then fails bronchoscopy. What do you want to do next for this patient once they fail for bronchoscopy? All right, so I'll break you out and I'll give you guys a couple minutes, okay? All right, I think everyone back. How about we hear from breakout room number 1 first? What do you guys think about the main case, and then we'll go into your mini case. Anybody? Maybe Travis?
Sure. We were thinking anything from like malignancy, AVM, vasculitis, infection of like tuberculosis, fungal, TB, septic emboli. What did I say? AVMs. Trying to think what else we had. For workup, we were thinking just a BAL, CT, sputums for regular and acid fast, CVC if we didn't get one already. I feel like I'm missing something big from our differential that we talked about.
We
How about
talked about
for-
like bronchiectasis and MAC.
Bronchiectasis and MAC too. Okay. Yeah, that's.
Yeah, and pulmonary embolism we had on there.
Oh, nice. Okay. PE as well. So you wanted the CT with the CTA?
Why not?
Okay. All right, sounds good. And that's I think the thing about the vasculitis that's always kind of interesting is that people don't, when they think of vasculitis, at least usually people think about, diffuse alveolar hemorrhage. They think about, CT of the chest with, big, basically diffuse like whiteout or a bunch of ground glass opacities. But, vasculitis, especially GBM, sorry, not GBM, GPA, granulomatosis polyangiitis, that can really present with something that looks like an abscess or a malignancy with these granulomatous necrotic masses in the lungs, and usually have this kind of central area of clearing. They can be all over the lungs and not uncommon for the patient to have, hemoptysis. A UA can also be really, really helpful in these cases, just to see if you have pulmonary renal syndrome as well. But let's go to your guys' case. What do you guys think this was?
So we were thinking a ciliary disorder or of like CF or cardiogenic.
Perfect. Causing specifically this lung pattern, right?
Yeah, with the possible compounded like active infection. Did it emerge?
Perfect. And then I think the big thing is that, would you say this patient, there's kind of 2 different categories of hemoptysis, right? There's scant hemoptysis, and then there is massive hemoptysis. And they're much different because one of them is not really that concerning. You definitely want to get to like why the patient's having a little bit of scant hemoptysis, but this can be someone just having a viral bronchitis. They're having a little bit of erosion of their larynx and pharynx and from coughing, and they have a little bit of scant hemoptysis. Not too big of a deal. But then there's massive hemoptysis. Do you guys think that your patient has massive hemoptysis? So we have a few cups of foamy blood in the last few hours. Do you guys think that counts?
I don't know how many cc's it would require, but unless it's like, if it's like on the hundreds of cc's overall, I would say yes.
Yeah, so absolutely. So it is 150 cc's over 24 hours. Now, this is kind of controversial. I think it changes, right? Like if it's a young patient, they have a really good lung reserve. They can probably tolerate a little bit of bleeding into their lungs, and they might not have any concerns for decrease in diffusion of oxygen until they get up to like, 300 cc's, 400 cc's. In the opposite spectrum, a patient with end-stage COPD, they might actually even get, life-threatening hemoptysis with something even less than this because they have basically no pulmonary reserve whatsoever. So getting into actually the approach to hemoptysis, I'll just go over the differential, and we'll start in this case with things that affect the bronchi. The bronchi have the bronchial arteries that basically run right adjacent to them, and anything that really erodes to that bronchial artery, can really cause massive hemoptysis. So one of the major causes of just hemoptysis in general is bronchitis. This is most common cause of hemoptysis, but it's almost always going to be scant. Not usually going to be concerning. It's just going to be more about inflammation of those bronchi. And these patients, will mostly have a pretty normal chest X-ray. The second one, and then the thing that we have in this case is bronchiectasis. Going through that CT in this case, the way that you know this is bronchiectasis is there's a couple classic signs. This sign right here, you can see the pulmonary artery right there, and then you can see the patient's bronchi right there. If the bronchi is larger than the pulmonary artery, this is called the signet ring sign. So looking out for that can be really, really helpful, and it's pretty sensitive and specific for ruling in bronchiectasis, especially in the absence of having interstitial lung disease. So this is a signet ring sign. These bronchi get dilated from basically being destroyed, and the artery also actually gets even smaller because you have hypoxic vasoconstriction to areas of abnormal lung. The other thing that you can see here is tram track sign, and this is basically this is pretty much just bronchi that are dilated, and bronchi are supposed to start tapering as they get out to the periphery, but you can see that these don't really taper very well, and that's another sign of bronchiectasis. So this is a patient with bronchiectasis, and the question was, this patient has massive hemoptysis right now, and we kind of got to this, but what would be your treatment for this patient right now? I guess first question is, if you had to put this patient on one of their sides, which side would you put this patient on? The side would you put them on the side that's bleeding, or would you put them on the other side? This is for anybody. You can put in the chat too. Yes, bleeding side is going to be down, right? You don't want that blood that's going in there to go to the other side, right? So you want to put that bleeding side down so that you protect the patient's good side. The other thing too is, if these patients need to be intubated, you want to selectively intubate the good side as well, so that that blood doesn't cross over and get into the patient's good lung, and you can maintain oxygen exchange in their good lung. All right, so you put this patient on the right side. What else may you need to do right now because this patient has massive hemoptysis? I think you should definitely get IR on board, but there's also another specialist that you might need as well. Yeah, so someone got it. So bronch. So the big thing you really want to do for these patients, and this is kind of your first go-to, is going to be a bronch and getting pulmonary on board. So there's a lot of things they can do with bronch. You're really going to need the CT. I know you want a dry CT and as well as a CT with contrast to first try to localize the bleed so that they know so that the interventionalists, the pulmonologists know kind of where they need to go. And then they can do certain things there. They can cauterize that bleed. They can use laser photocoagulation, put some saline on it, inject it with epinephrine, or they can even put a blocker there. So those are things that you can do to, in someone with massive hemoptysis, that you can definitely do to stop the bleeding. So bronch for massive hemoptysis is usually going to be your first go-to in most cases. All right, so that was case one. All right. Does anyone want to go from group two? Anything else they think about the case? I mean, this is a pretty good workup so far. Breakout room two, maybe Rashi? Any thoughts?
So I don't think we really had anything else to add. We were kind of focusing a lot on TB.
Okay. Sounds good. Remember, 3 stains for TB in a row has a sensitivity of about 65%. So remember, you always need to do it with a high clinical suspicion, but it's not always perfect to rule out. But remember, if you do a NAT, it does go up a lot. It goes up to like 90% sensitivity. So that's the case. I agree. I think the workup here is really, really good. Anything else you want to? Oh, how about for your mini questions? What were you guys thinking here?
So with the asthma and renal involvement, we were thinking maybe GPA. We also had some thoughts of like DAH, but that's less likely in eGPA, so maybe GPA.
All right, and I set this one up a little bit for a pulmonary renal syndrome, so you guys are right on the money. So pulmonary renal syndrome is kind of a catch-all phrase for things that you cause, changes in lungs, but also changes in the urine. This is a CT finding of actually DAH. So with diffuse alveolar hemorrhage, it's inflammation of your capillaries, the capillitis, and then bleeding into your alveoli. So you can see some of the outlines of actually like alveolar sacs and their secondary pulmonary lobules here. And the thing that clues you in and why anytime you're suspicious of this is you always want to get a urinalysis. You want to look for protein, and you also, in this case, this patient has signs that there's something glomerular going on because they're losing RBCs from their glomerulus into their urine, and that's what the passing through that glomerulus itself is what making these RBCs pretty dysmorphic. So you guys are on the money. This is a case of diffuse alveolar hemorrhage. And things that can cause diffuse alveolar hemorrhage, let's say things that specifically can cause pulmonary renal syndrome, is usually going to be your vasculitides. So the vasculitides can affect your kidneys as well as your lungs. So GPA, eGPA, microscopic polyangiitis. Those ones, they're small. Really, your small vessel vasculitis are the ones that are going to affect this. Other things that can do this as well, lupus, and lastly, good pastures. The one thing that can help you with good pastures, obviously you're going to need the anti-glomerular basement membrane, but these patients actually don't have, this is kind of interesting, something I learned lately. They don't really have any systemic signs or symptoms. Most people with vasculitis are going to have this vasculitic prodrome, in which the patient's going to feel arthralgias, tiredness. They might have like low-grade fevers, things like that outside the hospital. Good pastures is just going to be like a normal person who wasn't feeling bad and comes in with, diffuse alveolar hemorrhage or, a worsening creatinine and glomerulonephritis. So I think that's one of the things that's kind of interesting. So I've actually set this case. I didn't make it anything other than pulmonary renal syndrome. It could be lupus, it could be eGPA. But how do you usually treat pulmonary renal syndrome from a autoimmune source, just in general?
Steroids.
Yeah, exactly. So high-dose steroids. And most times you'll start these high-dose steroids maybe even before you have definitive proof, like a renal biopsy or definitive serologies. But once you really have definitive proof of what it is, things that you really want to be really aggressive in these cases. So, sometimes with lupus, they'll add on cyclophosphamide. Sometimes with vasculitis, they'll add on rituximab. It's really going to be high-dose immunosuppression for these patients. All right, great. So that was mini question number 2. And that kind of brings us to, so we've kind of went over the bronchial causes of hemoptysis. We went over bronchitis, bronchiectasis. Bronchiectasis is actually 40% of massive hemoptysis. So 40%, it's really I didn't know this, but the most major cause of massive hemoptysis is bronchiectasis. I didn't go over this too much, but bronchial neoplasms, whether they're primary or metastatic, is about 25% of all massive hemoptysis. And then we kind of get into the parenchymal categories. The interesting thing is, I think when we think about hemoptysis, we always think about TB, and infections themselves is about 13% of all cases of massive hemoptysis. But TB is actually only 3%. And in the US, an aspergillus is actually a little bit even more common than TB. So TB is the most common cause of hemoptysis in other countries, but at least in a study they did at MGH, in which they found everyone who actually had to undergo bronchoscopy for massive hemoptysis, and they looked up what were the most common causes. It was really bronchiectasis, cancer, and then infections with TB actually not being super common. Other things that can cause parenchymal, we have pneumonia, we have diffuse alveolar hemorrhage, kind of autoimmune causes. I don't know why I put this on here, but it's interesting to keep in mind that catamenal, meaning women who have basically metastases of their uterine tissue into their lungs, can actually even get hemoptysis during like their menstrual cycle. So a young woman or women who is still having menstrual cycles that's having hemoptysis right around their periods is just something to think about. So that's kind of our second big category. Let's go through for mini question number 3, breakout room 3. Do you guys have anything to add to our case? Who's in breakout room 3?
We threw sarcoid in there. I don't know if anybody said that yet.
Okay. Yeah, you have a lung mass for sure. That's good to be concerned about. Anything else? I mean, we have a really good workup so far. We have a BAL with bronch. Anything else to add to this workup at all?
UA.
Yeah, I think UA, absolutely. All right, and then how about your mini case? What are you guys thinking this was?
So we talked about it in like 45 seconds.
I made it too easy, didn't I?
Well, we think it's I think it's a PE.
Okay, yeah. Why do you think that? You're right, but why do you think
It's
that?
like a wedge. The CT shows a wedge infarct, I believe, like in the periphery. And then he's a guy with cancer. He's tachycardic, hemoptysis. Yeah.
Mm-hmm. Yeah, I thought maybe this would throw you off, but that there's opacity in the lungs. But remember, with a small minority of cases with a PE, they can get emboli to the periphery, and basically, here's your secondary pulmonary lobule here. Your artery goes into it here, and if you get clogging of this artery, you're going to get actually an ischemic infarct in the patient with PE. And when someone comes in with a PE and they have a pleuritic chest pain and they also have hemoptysis, that's actually usually a sign that they have a pulmonary infarct. That hemoptysis is actually going to be breaking down, like ischemic breakdown of that lung tissue. And that pleuritic chest pain is basically chest pain from a small amount of ischemia that's happening into the lungs. So I thought maybe I'd get you guys a little bit with this opacity, but you're too good. Specifically after Journal Club yesterday, how would you want to treat this patient?
So we were a little skeptical to start anticoagulation because of the colon cancer. So we might get a CTPE first to like evaluate clot burden.
Sure.
See if there's another option to like remove clot that way. And I didn't tune in for Journal Club.
It was the Cavaggio trials for starting Eliquis in patients with cancer. And I think that's what we usually, it used to be Lovenox, but you could get away with Eliquis for this patient. So this patient, definitely go over their risk for bleeding. But I think in this patient we would be okay with Eliquis as long as you rule out, you could start in the hospital as long as the patient doesn't have a procedure coming up, or if you don't think that they're going to need like a TPA or anything like that. And she wasn't a high risk patient. I didn't say that. So yeah, you could consider Eliquis based on the Cavaggio trials. All right. So that brings us to our last category, which is VTE. Not a ton of patients, but around 5% of massive hemoptysis can be from a VTA. And this patient had scant hemoptysis, but you can get massive hemoptysis from a PA. Other things that are in the vascular category are things that we brought up already: AVMs and aneurysms can absolutely bleed. And then anything that causes that high pressure, specifically in your wedge. That high pressure can cause a backflow of congestion into the lungs, and that congestion can actually cause papillary rupture. So the most, thing we're always taught is mitral stenosis, but congenital heart disease can do this as well. So just think about things that, you might need to get an echo in these patients if you have a concern that it is actually from a high wedge pressure. fracture. And then you might have some pulmonary edema on your chest x-ray that can kind of clue you into this. So that brings up our last category. You guys got it. This is just a picture of the chest x-ray finding of a wedge opacity. And, you know, this used to be called the Hampton's hump. Not commonly found, really insensitive for a PA. But when you do see a wedge infarct, something that looks like a wedge out in the periphery, you know, that can be a sign that the patient just had a PA. All right. So last question for group 4. Anything else to add to our case and at all on anything? And what do you guys think of this mini question? Maybe Max? This is making up for you beating me in spike ball. I'm gonna pick on you.
Nothing else to add for the like central case.
Mm-hmm.
In terms of this particular case, we were thinking that it was probably Aspergillus.
Ooh, okay.
Heavily aided by the patient's name.
Yeah, I thought I took that out. I don't know. It's gonna. I was worried I made this one too hard, so I put a little hint there.
And then we were thinking, so if the patient fails bronch, the next step would be, we were worried that like oral medications wouldn't be able to like sufficiently penetrate the fungal ball. So we were thinking like like a BATS procedure or something like that.
Yeah. And so next thing, absolutely. So, you know, definitive treatment for these patients is going to be surgery. I put this one in here because I think honestly, I would like to have like a pulmonologist on with us or someone who does thoracic surgery. But, you know, if someone's having massive hemoptysis right now, you could consider doing bronchial artery embolization. This patient had already failed bronchoscopy. So your next step, and you know, people had brought this up before, is, you know, when do you do IR? If they can't tolerate bronchoscopy or they fail bronchoscopy, or if you don't think it's going to work, in those cases, you'll do embolization. In this case, I specifically made it because of what you're saying, that these patients may be someone that needs surgery. And you're right, like this fungal ball is, you know, not close to really any blood, so no blood can really get there. So treating this patient with voriconazole not really going to do anything because this fungal ball is not, you know, the blood has no ability to actually get there. So for these patients, you know, if they fail all 3 of these, you know, these patients may need surgery with a wedge resection, and that's really for any hemoptysis. If they fail bronchoscopy, fail embolization, and it's massive hemoptysis, you know, you do need to think about resecting whatever that lesion is, whether it's a bleeding AVM, whether it's a bleeding fungal ball, or whether, you know, it's an area of the lung with bronchiectasis that keeps bleeding over and over again. All right, so that is pretty much our case. I think we have not too much time left. What happened in the primary case, Rebecca? Did we have any outcome?
So no outcome yet, but while at the outside hospital, there was a high suspicion for pulmonary tuberculosis.
Mm-hmm.
So the patient was placed on RIPE therapy, but he had 4 negative AFB smears, and
Okay.
Corngold was negative. MTB PCR from the sputum was also negative.
Okay.
HIV was negative. And he was seen by various consultants, and because there was lack of risk factors and negative testing, they thought that he should be tested for malignancy, given that he's an active smoker. So they stopped the 4-drug therapy and transferred him to us.
Okay. So I'm guessing he's probably gonna go
They
for
did
biopsy
today or yesterday.
Okay.
Yeah.
And you know, thinking about it, just in the U.S., like always have TB on the differential, but you know, at least from MGH, TB was TB itself was only about 3% of all cases. So, and then neoplasm was actually literally 5 times that amount at 25%. So, you know, this patient, I think we had concerns for TB and may have had an old TB or fungal infection, but it sounds like this is a patient that actually had one of the more common causes of hemoptysis, and that being cancer. All right.
actually being worked up for fungal infections though, because of all the calcifications that he's having.
Oh, that definitely makes sense. Yeah, absolutely. All right. Any questions about the case or anything? All right. Thanks, everybody.